Thank you, Virginia. Thank you, Raymond. As you saw, it's quite difficult to define. It's quite difficult to monitor because we don't have a final definition, but at the end of the day, we want to avoid the ischemia of the tissue. And so there are no conflict of interest for the presentation. So I would like to discuss about preventive strategy before, and then I will present you some unpublished data on a failure of a recent pharmacological trial, and then we will discuss about potential strategy, increase of blood arterial pressure, volemia, endovascular rescue. So starting from the first point, we would like to prevent in medicine, but we are not so good probably in preventing. And if you refer to the last edition of the American Heart Association guidelines on SIH, we see in color, green means there is a strong evidence, red means don't do it, yellow and orange means that the class of evidence behind the recommendation is quite low. So going in the direction of saying what we can do for preventing the reduction of the caliber and the ischemia caused by the reduction of flow, oral nimodipine, and the clinical evaluation when we are able to do it are green in this flow chart. So it means that the evidence behind is quite strong. And the evidence is very old, because if you look at this trial, it's been published in 1989. And they were also searching the changes in flow using at that time TCD. And they were not able to see any TCD change in the group treated. But at the end of the day, due to the reduction of the influx of calcium in the cell, there was a benefit in patients treated with nimodipine. So if we refer to the guideline, these are the Neurocritical Care Society guidelines, and are similar to the American Heart, there is a strong recommendation due to many trials to use oral nimodipine. That is very simple, but real life is quite a little different, because when you start nimodipine, pressure usually goes down. And so there is a problem of tolerance of the drug, and so sometimes we use dose splitting, sometimes we reduce the dose, sometimes we withhold the dose, and sometimes we stop the dose. So we have a treatment that has a strong documentation, but in real life there are some problems, and also there are some discussion on a reduced timing, usually at 21 days of infusion. So it seems logical to think about work on volemia, but against liberal fluid there are a lot of elements, not only in SIH patients, but generally speaking in intensive care, due to the risk of pulmonary edema, so we don't suggest to do it. And also, if we want to be guided by monitoring the more severe patient, the recommendation is very low quality. Even if we, in some patients with pulmonary edema, cardiac dysfunction due to SIH, and in monitoring of the cardiac function and optimization could be used as individualized therapy. And so also before the event, increasing cardiac output is not suggested because of the risk of doing that when it's not needed. We are talking till now of preventive strategy, when the patient comes in your unit after the bleeding. So Fabio discussed which of the system we are using for monitoring the problem. And as has been said, the clinical evaluation, when possible, is the mainstream evaluation you can have at bedside. More severe patients, this is not possible. And the options here are indicated: CTA, Doppler, EEG, and oxygenation. So everything that Fabio said. But as you can see, the evidence behind each of them is a little bit different, because some of them are more easy, like the Doppler evaluation. Some of them are more difficult, like EEG, to be implemented bedside. So probably, as in many other diseases, we are thinking about to use some drugs for solving the problem, like nimodipine for preventing. And in the past, looking at the mechanism of the disease, endothelin was one of the markers of the reduction of caliber of the vessel. So trying to make an antagonism of this mechanism looks a good idea in pharmacological trials. So 2 trials already has been published, Conscious 1 and Conscious 2. Both of them did fail. But in a sub-analysis, because medicine goes also looking at subgroups, in which the thickness of the supraannular blood was thick and diffuse, there was a potential reduction of the problems, ischemic problem after the disease using this drug. And so we started to think about another trial on the antagonist on endothelin-1. This trial has been finished last year. The database has been closed on December 13. And as you can see, the antagonist is being used, is a randomized control trial, for having a studied endpoint, reduction of the clinical deterioration due to DCI, and reduction of cerebral infarction and long-term clinical outcomes. So the overall, avoiding the problem, avoiding the consequences of the problem, so the infarction and outcome. Unfortunately, the primary outcome wasn't reached. There were more clinical deterioration in the treated population. And if you look at 6-month outcome, the outcome of the population is not improved with the drug. So we remain with the recommendation that the Neurocritical Care Society proposed before the trial. And so there is a recommendation against the use of endothelin receptor antagonism. And looking at the question of the colleague before about magnesium, statin, and so on, there is a lot of evidence, even in the previous guidelines edition, that there is no benefit in starting this therapy with magnesium, for example, for treating or preventing the problem. So we remain with not so many strategies. The first one is a very old strategy, probably has been started before Fabio Taccone was born, and as you can see, observation usually drives our knowledge. And when the doctor were seeing a clinical deterioration at that time, they didn't have PuTO2, CTA, angiography, and so on. They started to increase the pressure, and the sign reverts. So the patient was not able to move the leg or the arm, they increased the pressure, and the patient started moving again. And so they are starting thinking what's going on. But think at that time, 1968, patients were usually in very negative fluid balance, all the neurocritical care patients. The arterial pressure was kept down, and the patients were very high hemoglobin because they were very concentrated. So started the idea to use a triple H therapy, means hypervolemia, hypertension, hemodilution. But this small study, physiological study by Munk in Germany, is a mainstay study because it gives us the information that whatever you do of the 3 elements, the blood flow goes up. But if you look at the availability of oxygen in the tissue, because we are talking about delayed cerebral ischemia, so not enough oxygen to the tissue that produces damage, only hypertension was able to drive more oxygen in the tissue. So it seemed reasonable to discard the others and to think about the increase of arterial pressure that could be done softly or could be done rapidly after the clinical deterioration. And doing rapidly seems to be more beneficial. But we are not happy always to do the same things because for doing that we are using usually noradrenaline at the bedside. So we love to look at other drugs, and for example, Milniron is being used in small clinical trial, mainly in French-speaking country. And so looking at the result in this bar, and this bar are Milniron, you can see that they use both. Milniron plus norepinephrine for increase the arterial pressure. But at the end of the day, the patient, even if the trial was small, and this is a a small evidence that brings the idea that increasing cardiac function, working on the vessel, because the drug works on both, could be beneficial. A larger trial is ongoing for demonstrating this effect. But Fabio already presented something. Probably we need, when we increase the pressure, to take a look at the effect in the tissue, if we can select, as has been questioned before, the right patient, the more severe patient. And when we guide our treatment with a probe, PTO2 or EEG or whatever you want, probably we are better in reaching the aim. Because we know what is written in the book, but two centers, for example, one center is one of the chairman, did approach differently the same population, SIH patient. And if we look at the oxygen availability, having two different thresholds produce two different effects. So we need to think about the level of pressure. But often we are not satisfied because the clinical sign doesn't return back when we increase the pressure, because the reduction of flow is very important. And even if we take a look at the invasive monitoring EEG or PTO2, the reversion of the signal is not there. So we start thinking about endovascular rescue. And in the guidelines, this is orange. So the evidence is not so strong, but is suggested to be evaluated. And so we can do, when we go into the angio suite that need to be available every day around the neurocritical care unit, we can use drugs, but you can use also cerebral angioplastic. Why we can use both or think about both? Because intraarterial vasodilators works on proximal and distal vessel, mainly distal vessel. But we want to enlarge the larger vessel, so in many occasions in our center we prefer to test intraarterial first and then to go very fastly to the cerebral angioplasty, because if you look at the outcome and the success of the therapy is quite variable, but is more stronger if we use cerebral angioplastic. And the other point is that we have a lot of drugs that we can use because there is no evidence. You can see papaverine, nimodipine, nicardipine, milnirone, and so on. Every center uses on, and we don't have a final answer here. But at the end of the day, we are able to see when we inject the contrast that the vessel enlarge a little bit and the distal vessel have a more flow. So when we decide to go there, we need to decide to define a futility of a medical therapy, so a failure, and we need to be fast, because if we wait too long, like the CT scan that Fabio showed us, it's too late for trying to enlarge the vessel and to increase the flow. And so you need to go to the angio suite, and probably if you use a drug, you have to return back more than once, and to check the efficacy when the patient returns back to the unit. And so we, at the end, prefer, after a test, to work with, on the larger vessel, balloangioplasty for resolving the problem, because there is a disease of the vessel. The vessel is damaged, and the caliber of the vessel is more rigid, lose the possibility to have a good autoregulation, is thicker than the normal vessel, and enlarging the vessel is much more useful. And when to do it? If you do it on monitor, or if you wear a clinical deficit, produce a different approach, because you go more often if you look at the TCD, PTO2, EEG. But if you do earlier, delay cerebral infarction, so a tissue damage will be less present if you do early the procedure. So concluding, I have 50 seconds. Dear Chairman, I am on time. So preventive strategy, we only keep nimodipine on board, and we keep an eye on the patient, so neurological exam still is important. Unfortunately, we are not able to change the trajectory of the disease with new pharmacological trials, and the disease is not so frequent, even if we see frequently SIH patients, so there is not so a big drive on the company to test new drugs. Euvolemia, arterial pressure, neuromonitor guidance could be the solution for avoiding the tissue damage, and if we fail A timely implementation on endovascular rescue, discussing with your angiographyst is important. And my last suggestion is to act with wisdom as ever, because in some patients, if we do it too late, it's probably we can produce more damages than benefit in this situation. Thank you.
Thank you, Giuseppe, especially for the excellent talk and for keeping in time. Are there any questions from the audience? Yes, over there.
Thank you for the very nice presentation. I have a question about the endovascular rescue therapy. So in the practical life, when do you use it? So how much do you raise your blood pressure and how long do you wait? And do you do it only for new neurological deficits in awake patients or only based on invasive neuromonitoring? Thank you.
So the question is very tricky because we don't have a clear answer, but we start increasing the pressure very soon. And compared to the past, I discuss a lot with my colleagues, and we change the staff sometimes in our unit. And new colleagues are less keen to increase arterial pressure because they are worried about that. But when you see that increasing arterial pressure, if you want a threshold, in a normal patient, I go 180 systolic, 200 millimeters of mercury systolic blood pressure, if the patient doesn't have big other aneurysm, or the aneurysm is not fully closed, because sometimes it's only protected. So if the securing of the aneurysm is not possible angiographically, rising the arterial pressure could be a problem, and so we can take more caution. But if a patient doesn't have systemic problem, cardiac problem, we raise the pressure. We immediately look at the result if the patient could be clinically evaluated. In most patients, the sign return back to normality, increasing the pressure. If we have some endpoint, that it could be a monitoring endpoint, EEG, alpha-delta ratio, PTO2, or angiography, we do an exam again and we check if we solve the problem. We don't use TCD for looking at the result because increasing the arterial pressure, TCD, blood flow velocity goes up. So you cannot answer the question correctly with TCD. So we look at an endpoint, but the message is as soon as possible. You cannot do, as Fabio said, an angiography or an angio-CT every hour. But after 2 hours, if you cannot visit the patient, after 2 or 3 hours, go again and to test. Or what we did many times in the past, test the angio with 2 different levels of pressure and see the flow at 2 different arterial pressure levels. But the message is to act fastly, control immediately, and if you are not satisfied, start discussing immediately with your neuroangiographyst. And the problem is that you always know the timing of this story, because we didn't discuss about timing. The timing of the story is not the day 1, it's not the day 2, it's not the day 3, it's around day 7, 5 till 10. So we have a timing in which your eyes look at this problem more closely, and you need to act very rapidly in that time period, mainly.
I think very, very important message, especially the time constraints we have, and that happens in the weekend, Friday night, and so if you think about it, do it rapidly, and I think that's
you need
very
to
important.
do also on the weekend, for sure.
Sure. So another question?
Thank you. My name is Carlos. I just wanted to ask, what do you do when your patient is awake and is clinically deteriorating, like has a vasospasm? Do you intubate and go full heads on, or do you follow the clinical status of the patient?
If a patient could be evaluated, for example, a start hemiparesis or another clinical sign, I work on the pressure, but I don't intubate the patient at that stage. If the patient has a loss of consciousness, reduced consciousness due to the vasospasm, you have to protect the aorta. But if the aorta are protected, I prefer to work on pressure because intubation usually asks also a little bit of sedation, and a little bit of sedation asks more vasopressor. So at the end of the day, there is no evidence of a benefit of intubating the patient when a focal neurological sign appears. I'm not saying a global, a focal neurological sign.
One last question, yeah.
When you augment blood pressure and it doesn't work, will you go to angiography or will you, before doing that, add milrinone? And the second question is, if you augment blood pressure, how long will you maintain it and when will you decrease it again?
Okay. The first point, if I add milrinone, we did it sometimes. We are not so keen to use it because we are not so used to use it, but the evidence is coming, and I will wait for the clinical randomized control trial. If the evidence will be more strong, I will do it for sure. When to reduce the arterial pressure, I got the second question is okay. We wait 1 or 2 days and then we start tempering down the arterial pressure, controlling the effect of the reduction of the arterial pressure. Usually you have to, sometimes you have to return back to the previous level, but if you look at the disease in animal, after day 15, between 15 and 21, the vessel tend to return back to normality. So if you pass after day 14, usually you can taper the vasopressor more rapidly.
Okay, thank you very much. I think we have to close the session now. Thank you, Giuseppe, again. And I would like to thank all of you for that great discussion. I learned a lot, and novel strategies. It shows that we actually organize something like that also in the next meetings. Thank you so much. Enjoy the meeting conference.